The World Health Organization has finalized an assessment that marks a critical turning point in global public health surveillance, confirming that the Andes strain of hantavirus is capable of spreading directly between humans via airborne respiratory droplets. While classic hantaviruses are notorious for restricting their transmission strictly from infected rodent reservoirs to humans, this verified shift to person-to-person aerosol transmission elevates the Andes virus to an unprecedented level of epidemiological concern. For years, the international scientific community treated hantavirus outbreaks as localized, sporadic hazards tied exclusively to rural environments and specific agricultural or domestic cleaning activities. This new confirmation shatters those long-held assumptions, demonstrating that once the virus iblis establishes itself within a human host, the breath of that individual can become a vector for further infection. Viewers must understand that this development changes not just how medical personnel approach individual patients, but how global border authorities, transport hubs, and municipal health departments structure their containment protocols. The Andes strain, primarily native to South America, has historically carried high mortality rates, causing severe hantavirus pulmonary syndrome characterized by rapid respiratory failure. By confirming that human breath is now a viable transmission pathway, health authorities are signaling that the virus no longer requires a direct ecological bridge to wilderness rodents to sustain a chain of infection in human communities. This shift introduces a complex layer of risk for urban environments, medical clinics, and transport networks where close proximity is unavoidable. The underlying virology of hantaviruses typically involves an incubation period where the virus replicates undetected before unleashing a severe inflammatory response in the lungs, making early identification difficult and rendering person-to-person aerosol transmission particularly hazardous in crowded or poorly ventilated settings. Operational reports from international health agencies, specialized laboratories, and regional clinics reveal the immense pressure this confirmation places on diagnostic networks. Surveillance teams are now re-examining cluster data to differentiate between independent spillover events from infected rodents and hidden chains of human-to-human transmission. According to official data and monitoring criteria, hospital isolation wards must immediately upgrade their defensive postures, shifting from standard contact and droplet precautions to full airborne containment infrastructure. Lab specialists emphasize that verifying aerosol transmission requires meticulous genetic sequencing and contact tracing frameworks to rule out simultaneous exposure to the same environmental rodent source. In the field, clinicians are reporting that the clinical presentation of the Andes strain begins with deceptive, non-specific flu-like symptoms before rapidly deteriorating into catastrophic pulmonary edema where the lungs fill with fluid. Health officials stress that existing commercial diagnostic kits must be deployed rapidly at the first sign of cluster formations to prevent healthcare facilities themselves from becoming amplification points for the virus. International shipping, travel, and logistics networks are also reviewing these findings, as the potential for an asymptomatic or mildly symptomatic traveler to board a flight or vessel and exhale viable viral particles in an enclosed cabin represents a major vulnerability in global biosecurity. Public health statements emphasize that while verified cases of human-to-human transmission remain tied to specific geographic zones and close contact clusters, the confirmation of the aerosol mechanism means that containment strategies can no longer rely solely on rodent eradication or avoiding rural cabins. Prevention and public guidance are undergoing an immediate overhaul to reflect the reality of airborne hantavirus transmission. Standard public health advisories continue to emphasize classic environmental precautions, such as using disinfectants rather than dry sweeping when cleaning areas where rodents may have nested, as traditional sweeping stirs up dried rodent excreta into infectious dust. However, because human breath is now a confirmed vector for the Andes strain, guidelines for families, caregivers, and frontline medical workers now mirror those used for severe respiratory pathogens, mandating high-efficiency respirators, proper room ventilation, and strict quarantine of suspected contacts. Surveillance networks are expanding their footprints to monitor urban peripheries and transit corridors where human density could accelerate an outbreak. Significant uncertainties still remain, as scientists do not yet know the exact viral load required to initiate an infection through human breath, nor is it entirely clear how long the Andes strain remains stable as an aerosol in different humidity and temperature conditions. Public health agencies urge calm, noting that the virus does not possess the extreme transmissibility of common respiratory viruses, but they insist that vigilance must remain absolute until therapeutic or vaccine countermeasures are fully validated. For ongoing updates on global public health developments and breaking medical reporting, consider subscribing to this channel. Operational reports from international health agencies, specialized reference laboratories, and regional clinics reveal the immense technical and administrative pressure this formal confirmation places on diagnostic networks. Surveillance teams are now actively re-examining historical and current cluster data to differentiate between independent spillover events from infected long-tailed pygmy rice rats and hidden, undocumented chains of human-to-human transmission. According to official data and newly updated monitoring criteria, hospital isolation wards must immediately upgrade their defensive postures, shifting rapidly from standard contact and droplet precautions to comprehensive airborne containment infrastructure. Lab specialists emphasize that verifying true aerosol transmission requires meticulous genetic sequencing and rigorous contact tracing frameworks to definitively rule out simultaneous exposure to the same environmental rodent source. In the field, clinicians are reporting that the clinical presentation of the Andes strain begins with deceptive, non-specific prodromal symptoms such as fever, myalgia, and profound fatigue, before rapidly deteriorating within hours into catastrophic pulmonary edema, where the lungs fill with fluid due to increased vascular permeability. Health officials stress that existing commercial diagnostic kits, including polymerase chain reaction assays and enzyme-linked immunosorbent assays, must be deployed rapidly at the first sign of cluster formations to prevent healthcare facilities themselves from becoming amplification points for the virus. International shipping, commercial aviation, and logistics networks are closely reviewing these findings, as the potential for an asymptomatic or mildly symptomatic traveler to board a flight or vessel and exhale viable viral particles in an enclosed cabin represents a major vulnerability in global biosecurity. Public health statements emphasize that while verified cases of human-to-human transmission remain historically tied to specific geographic zones and close contact clusters, the confirmation of the aerosol mechanism means that containment strategies can no longer rely solely on rodent eradication or avoiding rural cabins. Furthermore, health ministries are facing a severe shortage of negative pressure isolation rooms in regional hospitals, forcing administrators to consider temporary containment structures and the rapid deployment of mobile laboratory units to affected zones. Discrepancies are already emerging between local official statements, which tend to emphasize that the outbreak is contained, and independent epidemiological models that suggest a higher reproductive number for the virus when confined to indoor spaces. The World Health Organization's verification serves as a mandate for immediate funding reallocation toward international biosafety Level 4 laboratories, which are the only facilities equipped to handle the live Andes virus safely. As testing capacity strains under the surge of suspected cases, laboratory personnel are working under heightened biosafety protocols. Knowing that a single needle stick or a failure in air filtration could expose an entire facility to an airborne pathogen with a mortality rate exceeding 30%. Regulatory bodies are also fast-tracking reviews for experimental antiviral treatments and monoclonal antibody therapies, though officials caution that widespread distribution remains months away. Shipping hubs are experiencing localized delays as port authorities implement health screenings for crews arriving from high-risk endemic regions, balancing economic continuity with the urgent need to prevent the geographic export of a newly confirmed airborne threat. Prevention strategies and public health guidance are undergoing an immediate fundamental overhaul to reflect the stark reality of airborne human-to-human hantavirus transmission. Standard public health advisories continue to emphasize classic environmental precautions, such as using liquid disinfectants, bleach solutions, or detergents to thoroughly wet down areas where rodents may have nested, rather than dry sweeping or vacuuming, as traditional sweeping stirs up dried rodent excreta into highly infectious dust clouds. However, because human breath is now a confirmed vector for the Andes strain, guidelines for families, immediate caregivers, and frontline medical workers now closely mirror the strict protocols used for severe acute respiratory pathogens. This mandates the immediate deployment of high-efficiency respirators, such as N95 or FFP3 masks, the implementation of aggressive room ventilation protocols, and the immediate strict quarantine of all suspected close contacts. For the general public, practical takeaways include avoiding poorly ventilated indoor spaces in known endemic regions, monitoring local health bulletins for unexpected cluster notifications, and seeking immediate medical evaluation if flu-like symptoms develop after a known or suspected exposure. Surveillance networks are expanding their operational footprints to monitor urban peripheries, informal settlements, and busy transit corridors where high human density could drastically accelerate the reproductive rate of an outbreak. Significant scientific uncertainties still remain, as researchers do not yet know the exact minimum viral load required to initiate a successful infection through human breath, nor is it entirely clear how long the Andes strain remains biologically stable as an aerosol in varying indoor humidity and temperature conditions. This gap in knowledge places a profound ethical responsibility on public health agencies, international media, and local governments to communicate transparently without inciting panic. Officials must strike a delicate balance, avoiding the minimization of a high-mortality pathogen, while ensuring that resources, medical countermeasures, and diagnostic kits are distributed equitably to vulnerable populations rather than hoarded by wealthy metropolitan centers. The ethical imperative extends to data sharing, where regional governments must report suspected human-to-human clusters swiftly and accurately to the international community, prioritizing collective global health security over localized economic or tourism interests. Public health agencies urge calm, noting that the virus does not currently possess the extreme, unchecked transmissibility of common seasonal respiratory viruses. But they insist that vigilance